Should we be giving powerful weight loss drugs like GLP-1 to children with obesity? Some experts are pushing to start earlier. Others say we may be making a mistake we won't be able to reverse. Now, treating children is never simple. You're not just treating a condition, you are shaping a developing system. Some will argue if you don't treat early, you are allowing that biology to tighten its grip, and by the time that child is old enough to choose, the struggle may already be deeply wired in. While others, they will say we are over-medicalizing a complex problem and potentially placing children on powerful medication before they've even had the chance to understand their own hunger, their own habits, or build a healthy relationship with food. And this is where families get trapped, because every day parents are watching their child struggle. Struggle with weight, struggle with confidence, struggle at school, struggle socially. Some are terrified of doing too little. Others are terrified of doing too much. And just when you think one side is right, the ground shifts again. I am Dr. Almerie, consultant weight loss surgeon and obesity specialist. In this video, I'm going to break this down step by step, not just through the research and medical evidence, but through the reality we see in clinical practice and the difficult decisions families are already facing every single day. This will give you the chance to see the problem through the lens of both the doctors and the parents, so you can understand why this decision is so difficult and build your own position on something that could affect the people closest to you. Let's explore this. Before we go further, I want you to picture something. If you have a child or know someone in this situation, this will feel familiar. If you don't, just imagine it. A 14-year-old child, already around 180 pounds. You are a careful parent. You try to do the right things. But this child is different. The appetite is constant, always thinking about food. You walk into the kitchen, they are at the fridge. At night, they wake up hungry. When you eat out, they eat more than everyone else. And if you try to stop them, they feel deprived. They feel you don't understand them. Their siblings, they are fine. But this child finishes everything. You've tried to manage it. You've asked for help. Doctors, programs, diet plans. For a while, it works. Then it stops. And the weight keeps going in one direction, up. And you are left not knowing what to do. Because this is not a child who is a bit chubby. This is something much deeper. And that is who we are talking about here. And if you are watching this, you might be thinking, why is this happening? Because this doesn't feel like normal behavior. And the uncomfortable truth is, it's not. Because this is not just behavior. This is biology. Now, obesity does not suddenly appear at 25 or 30. In many cases, it starts early. It builds over years, and by the time someone reaches adulthood, the biology is already set. Insulin resistance, appetite dysregulation, fat storage patterns, and in many cases, early disease is already there. Type 2 diabetes, cardiovascular risk. So if we wait, we are not being cautious. We are allowing the disease to progress. Because in most cases of childhood obesity, the trajectory is not unclear. It is predictable, and it almost always moves in one direction. Forward, worse. And that leads to an uncomfortable conclusion. For some children, early treatment makes sense. But this is where things become more complicated, because now you are not just treating a disease. You are deciding on behalf of someone who may not fully understand what that decision means. A child can't fully process long-term risks. They can't fully grasp what it means to start a treatment they may need to continue for years, or what happens if it stops. Now you might be thinking, is that not what parents are meant to do, to decide in the child's best interest? And that is true, but this is different here, because this is not a short-term decision. This is not a temporary treatment. This is not emergency surgery where you fix it and then you step away. This is something that may shape their physiology and their psychology for years to come. And one day, you may have to explain that decision to them. But here is the other side of this, because the reality is this treatment works. I remember a mother who came back to clinic after her 14-year-old child started a treatment. Not after weight loss, as it had not happened yet. It was only a few days into treatment. She came in crying because for the first time in her child's life, he felt calm. Something she had never seen before. He was not constantly searching for food. He was not raging for it. She didn't have to lock food away anymore. And she said, "I don't care about the weight. I have my baby back." And that is what this treatment could offer. It calms hunger. It quiets food noise. And for the first time, it gave her child space. Space away from the constant pull towards food. And in that space, weight loss becomes possible. But more than that, life becomes quieter. And that's why this matters. Because this is not just about weight, it's about relief. But this is where the ground shifts again. Because what we know is only part of the story. And what we don't matters just as much. Because here, you are intervening in a body that is still developing, not finished. Tissues and organs still growing. Biological pathways still developing. And that matters because we know this drug affects not just weight, but multiple biological systems. And when you step in here, you are changing signals we don't yet fully understand, including how they may affect the growth and biological maturation of that child. Most of the long-term data we rely on comes from trials on adults, fully developed systems, fully matured biology. But here we are talking about children, biology that is still being built, and we don't know yet how this will change them over time. So the risk here is different, not immediate, not obvious, but uncertain. And that is harder to deal with because now you are not just asking, does it work? You are asking, what is the trade-off in that child's development for that result? But here is the other reality. This is not a static situation. This is not a child staying the same while you decide. This is a moving situation because childhood obesity does not pause. It progresses. And we are not talking here about mild cases. We are talking about children gaining tens of pounds, sometimes even more. Children at the 99th percentile, where behavioral changes have already been tried, education programs, dietary advice, activity plans, and despite all of that, the trajectory often has not reversed. At best, it slowed down temporarily. And that is the problem, because this is not a parked car. This is a car already moving. And for some children, it's moving in one direction, towards the cliff. So doing nothing is not neutral. It's not safe. Because in this situation, inaction is still a decision and it allows that movement to continue. And the longer you wait, the riskier it becomes. But there is another layer to this, one that is less visible, but just as important. Because GLP-1 does not just affect weight, it changes hunger signals, food reward, eating behavior. And in the developing brain of a child, this is about pattern formation. Now think about it. Is the child learning control, developing awareness around food, or relying on medication to regulate that for them? Now you might be thinking, if the medication works, does that even matter? Well, it does, because this is the stage where patterns are formed. And if that process is altered, we may not be allowing that child to fully develop their own relationship with food. And that's where this connects to something bigger. Because what happens when the medication stops? We already see this in adults. Hunger returns, biology pushes back, and in many cases, the weight comes back. And in a child who has not fully developed that relationship with food, that rebound may even be harder. And that changes the nature of the treatment, because now it's not just something you use, it becomes something you may need to stay on, possibly for years, maybe even for life. And that raises a difficult possibility. Are we creating a generation that may have to rely on that medication long term? And for a child, that's not a small decision. So these are the tension points we now have to balance when making decisions about GLP-1 in children. Because this is not a simple question of, does it work? It's a question of, when do we intervene? How early? For who? At what cost? And what risk are we more willing to accept? The risk of treatment or the risk of doing nothing? Now the next question is, where do the medical guidelines stand on this now? What does the evidence actually show? And how are the doctors already approaching this in real clinical practice? That is what we are going to explore next. So where is this actually going? Because this debate is no longer theoretical, it's already starting to happen. We now have trial data in adolescents. One of the key studies, the STEP Teens trial, was published in the New England Journal of Medicine. It looked at adolescents aged 12 to 17 living with obesity. And these were not children who were just a little bit overweight. Their average weight was around 240 pounds, and their average BMI was around 37. So we are talking about young people with severe obesity, children already carrying real biological risk. And in that trial, semaglutide led to a significant reduction in BMI, around 16%. Now let's pause here, because this is not a small change. For a child on that trajectory, that's the difference between continuing down that same path or shifting it. And that's why this matters. But then comes the next question. What are medical systems doing with that evidence? In 2023, the American Academy of Pediatrics recommended that clinicians offer weight loss medication to adolescents aged 12 and older with obesity, not instead of lifestyle changes, but alongside structured support. And that changes things, because now this is no longer a theoretical option. It becomes a real option, a decision that parents and clinicians are starting to face. In the UK, the position is much more cautious. NICE, which is the body that sets national guidelines, has not yet made a routine recommendation for GLP-1 in young people. Their use is still being considered only in selected cases, often in specialist settings. So the UK is moving in the same direction, but not at the same pace. And that's where we are right now, right in the middle of a shift, where the benefits are becoming clearer, but the long-term consequences are not. And only time and further research will tell us whether the decisions we are making today will stand in the future. I am Dr. Almerie. If you've made it this far, you are someone who values evidence-based advice, and that's exactly what this channel is about. So if that's you, subscribe to support the channel and help bring you more medical advice that fits your style. Thank you for watching, and I will see you in the next one.